So I think we'll go ahead and get started. Welcome to today's seminar. This is hosted by the College of Public Health and Human Sciences at Oregon State University. I'm Marie Harvey. I'm the Associate Dean for Research in the college. And I'm pleased to welcome you, and I'm pleased to introduce Dr. Siu-Sun Wong, who is an Associate Professor and an Extension Nutrition Specialist in our college. And she will be moderating today's session and introducing our speaker. So let's get moving forward, and why don't we please join me in welcoming Dr. Siu-Sun Wong.
Thank you, Dr. Harvey, and good afternoon, everyone. It's my pleasure to introduce Dr. Jinan Banna, our speaker for today. A good friend I get to know for more than a decade ago through AES multi-state projects. Jinan is an associate professor in the Department of Human Nutrition, Food and Animal Sciences in the College of Tropical Agriculture and Human Resources.
Great, thank you so much, Siu-Sun. So today I'm going to be presenting the work that I've done related to preventing excessive gestational weight gain via text messages
and physical activity questionnaire to be used in the low-income Spanish-speaking community in the U.S. Prior to joining the University of Hawaii, Jinan worked in Lima, Peru to research on adolescent dietary habits. Jinan's research interest is in improving dietary intake of underserved children and adolescents, domestically and internationally, and developing tools to assess food, behaviors, and dietary intake, particularly in Spanish-speaking populations. Excess weight gain during pregnancy is associated with adverse outcomes during and after pregnancy. So Jinan's presentation today will discuss her work to address the need of a low-income population with regards to prevention of excessive gestational weight gain using technology. Her presentation is entitled Results of an Intervention Using Text Messages to Prevent Excessive Gestational Weight Gain in Hawaii, a Women, Infants, and Children program. If you have questions for Jinan, please type your question in the Q&A box instead of the chat box because it may not be available to the attendees. And at the end of the presentation, I will read your question to Jinan. So without further ado, please join me in welcoming Dr. Jinan Banna.
Thank you so much, Siu-Sun. And sorry, there was a strange technical glitch, and at one point in your presentation, there was silence, so I thought you had finished introducing me and I started talking. So hopefully you all didn't hear that because it was very strange. So glad to start my presentation now. And I'd like to start my presentation with a poll. So if we could put that up, that would be great. Great, so thank you so much for your responses. Looks like we do have a few people in the audience who have used some tools, technology-based tools to deliver education, so that's great, and others who haven't conducted research in this area or have delivered education using other methods. So that's good to know. And so I'd like to hear about your experiences using technology as well, and questions you may have about using technology. So to get started, we'll start by discussing weight gain in pregnancy. So of course, this is normal and necessary for support and development of the fetus. And we can see all the different components of the weight gain here. And we do have guidelines for healthy weight gain during pregnancy. And so of course, the guidelines say that we should have less weight gain if a woman is overweight or obese at the start of pregnancy than if she is at a healthy BMI. And so the ranges are given based on the pre-pregnancy BMI. And we also have the recommendations here in terms of what is considered excessive gestational weight gain. So my work is focused on preventing excessive gestational weight gain in pregnancy. And this is important because we know that excessive gestational weight gain is associated with many adverse outcomes. So we have an increase in gestational diabetes, complications in labor and delivery, and weight retention postpartum. And we can see that this is a big problem for overweight women, with about 60% gaining excessive weight during pregnancy. So it's an important topic of conversation. And of course, low-income women are particularly at risk because they are more likely to be overweight and obese and enter pregnancy in that condition. They're likely to have excessive gestational weight gain and diets that are low in nutritional value, so perhaps not meeting their needs for essential nutrients and consuming lots of empty calories. And they may take part in less physical activity, so they're an important population of interest. And we have health disparities in low-income women resulting from various factors. There may be lack of access to adequate health care, food insecurity, which remains a big problem in the US, low health literacy, and a lack of support for healthy behaviors and lifestyles. And in terms of the research needed with regards to excessive gestational weight gain, there was a committee to re-examine the Institute of Medicine pregnancy weight guidelines, who made a recommendation in terms of research to support women to meet the guidelines for weight gain in pregnancy and pay particular attention to low-income populations. And we know that traditional face-to-face interventions can be effective for achieving outcomes in some populations. And of course, we still use this method to deliver education in many cases, but our low-income populations may be harder to reach. There may be a lack of availability of programs in some geographical areas. It may be difficult for individuals to make it to the program. They may have concerns regarding transportation and may not be close enough to reach the physical program. They may have time constraints if they're working several jobs and perhaps caring for children. And there may be a cost involved in participating. So these are all barriers for low-income populations in terms of receiving health-related education. And in a systematic review of interventions seeking to promote healthy gestational weight gain, it was found that some interventions were only effective at reducing gestational weight gain in one group. So if they compared weight categories or racial or ethnic groups, then there was not across the board effectiveness in reducing excessive gestational weight gain. And in some cases, did not have any effect in terms of promoting healthy gestational weight gain. And most interventions were aimed at behavior change or education only, but it has been found that it is also important to focus on psychological aspects, such as motivation or body image, as participants may have concerns, for example, in terms of their body image. And there also has been a focus on either nutrition or physical activity. And of course, this is less successful than focusing on both together, which is what we have done in the study we conducted. And much of the literature evaluates face-to-face interventions and does not address the barriers that our low-income populations face. So there is a great need for interventions that use technology to try to address some of these barriers. And we have seen some success of mobile and internet-based interventions, and it has been shown that they are able to achieve significant weight loss at a lower cost. And in one study, we found that there was a greater proportion using a weight loss website who returned to pre-pregnancy weight than those with only the standard WIC care. So there has been some success shown with these interventions using these technology-based tools. And overweight and obese pregnant women have reported positive experiences with mobile and technology-based tools. So we have evidence for implementation of e-health or mHealth interventions. And we know that mobile phone ownership is widespread in the US. So most US adults own a cell phone, as well as most low-income adults. And we also know that low-income individuals use text message to a great degree. So here we have some information about use of text message according to level of income. So we can see that those with the lowest level of income sent and received the most messages per day. So they're great users of text message, and that makes this an attractive way to deliver education. So we can see that interventions using the short message service or text message may be cost-effective, sustained over time, and embedded into programs such as WIC. And so this is exciting because if we can show that this is an effective way of delivering education, then we can potentially use this as one of the main methods to deliver education in the WIC program, and thus hopefully reach more women and improve the way in which we deliver this education to address some of the barriers that these women are facing in receiving education. And we conducted a previous trial in WIC to improve infant feeding practices. So with my collaborator at Florida International University, we conducted this trial both in Hawaii and Puerto Rico. And we had high response and retention rates. We did not find any significant effect of our intervention on infant feeding practices or weight. So we thought that perhaps we could intervene before birth. So we took what we had learned in this intervention and we moved forward with the intervention that I'm presenting today. So there have been few studies using text message to promote healthy gestational weight gain. And in one study, there were text messages sent nearly every day to overweight and obese pregnant women, and there was no significant effect of the intervention found. In another study, there were 2 text messages sent per day to obese pregnant women, and they found that fewer intervention women exceeded the guidelines, so that showed some promise. And in another study, there were several different means of delivering education used, so not only text message, but also a website, videos, and social media peer group for overweight and obese pregnant women. And they did find that there was a lower gestational weight gain in the intervention group compared to the control group. And there has been no study examining the effectiveness of nutrition education delivered via text in preventing excessive gestational weight gain in low-income groups in Hawaii. So that's our focus. So our objective was to assess the effectiveness of an 18-week text message intervention to promote healthy eating and physical activity to reduce excessive gestational weight gain in a low-income population in Hawaii WIC. And our target population was 83 pregnant women participating in the WIC program. We worked with 4 different WIC sites here on Oahu. And our inclusion criteria were 18 years or older, having a gestational age of 10 to 20 weeks, a first trimester BMI of 20 to 45, and having a cell phone to be able to receive 1 to 2 messages weekly without a charge. So we screened participants for eligibility. We then explained to them the study and they completed the consent form. We obtained their weight before pregnancy. So this was self-reported at the start of the intervention. And they also provided information on demographics. We randomly assigned them to the intervention or control group. There was a 4-month intervention period during which we sent them 1 text message weekly. And we then obtained their last weight before delivery. And this was also self-reported. And we asked them to evaluate the text messages. So we conducted a qualitative in-person interview with women in which we asked them which messages they liked the most, which messages they liked the least, which messages led them to change their behavior. And we offered them the opportunity to comment on the receipt of the text messages and the degree to which they were interesting or annoying, etc. In terms of our intervention message focus, we focused on promoting appropriate energy intake and physical activity to help women gain the right amount of weight in pregnancy. And so some of our messages related to food substitutions. So for example, we encouraged them to drink water rather than sugar-sweetened beverages, to get enough fruits and vegetables, to make sure they weren't overeating and be aware of their portion size, and get the right amount of physical activity in line with the American College of Obstetricians and Gynecologists guidelines. And we developed our messages to be 160 characters or less. We had a total of 18 messages. And this was the limit for the, with regards to the program we were using to send the messages. So we had to keep it at that limit of 160 characters. And we focused on reinforcing WIC's recommendations for pregnant women. We developed our messages based on the social cognitive theory. So of course, this posits that learning occurs in a social context with a dynamic and reciprocal interaction of the person, environment, and behavior. And in terms of the cognitive aspect, we focused on self-efficacy, so increasing people's confidence in performing the behavior and increasing knowledge. We took into account the social and physical environment and the behavior. So this is an example here of one of our messages and how we incorporated the social cognitive theory. So we told them to have fruit where they could see it easily. So we took into account the environment. We were trying to see how they could possibly modify their environment to have that fruit easily accessible. We gave a specific recommendation to eat it every day. And we gave an example of the food. So this is one thing that came up when we did cognitive testing of our messages, which I'll discuss next, that people liked very concrete examples of what we were suggesting. And we included the knowledge and expectations here. So we tried to increase their knowledge of how eating that fruit would help them to achieve a healthy weight in pregnancy. And so, as I mentioned, we conducted cognitive testing with women to understand the way in which they understood the messages in the intervention. So we wanted to make sure that the wording was appropriate for the participants and that they were able to understand the words that we used. So we interviewed 5 pregnant WIC participants, 18 years or older, between 15 and 20 weeks of gestation. And they were asked to state the meaning of the messages in their own words and how to make them clearer for other WIC participants. So I should mention that this cognitive testing is a technique that I've been using for many years now, going back to when I was a graduate student at UC Davis. At that point, I was developing a questionnaire for low-income Spanish speakers and first became familiar with cognitive testing, and have used it in a numerous studies since then to try to improve the wording of questionnaires and messages. So really enjoy always my cognitive testing and find it to be a fun and educational activity. So here's an example of some of the modifications we made based on our cognitive testing. So we had a message that asked people to make half of their plate fruit and vegetables. We mentioned dark green, red and orange vegetables. And our participants told us that they really didn't know exactly what we were talking about, that our statements, or the words we were using were quite broad and they didn't help them to make choices in the supermarket. So they asked us to be more specific, and we ended up with a message that gave some examples of what we were referring to, so spinach, carrots, etc. Here's another example of some modifications we made as a result of cognitive testing. So we mentioned that participants should be getting enough iron, calcium, folic acid, etc. But participants mentioned that they really didn't know where to find, for example, iron or folic acid. So they suggested that we give specific examples of foods that contain these, and we ended up with a message that mentioned that they could get iron from meat and beans, and they could get folic acid from vegetables. In terms of our control group, we sent messages that were unrelated to healthy eating and physical activity and about general health in pregnancy. So for example, to make sure that they go get their checkups, to make sure that they get enough sleep, and other health-related topics such as immunizations, and other messages related to something other than nutrition and physical activity in pregnancy. We also assessed readability because, of course, we wanted to make sure that the messages were at the appropriate reading level. And we were shooting for a 5th grade level for a low literacy audience. And we used the Flesch-Kincaid formula to determine the reading level. So this takes into account the length of sentences and the length of words in the sentence. We had a final review of the messages, and we worked with an OBGYN with experience in low-income groups. So she reviewed our messages and gave us some suggestions about terms that we could consider using instead of those we had selected to make the language a bit more familiar to our audience. So there were only minor changes suggested for this step of the process. So here are some examples of our messages. So we discussed omega-3 fats. We gave some examples of foods that contain those omega-3 fats. You saw previously our message about iron and folic acid. We had messages related to physical activity, so trying to get people to engage in particular activities that could be incorporated into their day. And we gave specific examples of some of those activities they could engage in. And we delivered one message per week for 18 weeks, and our messages were at the 5th grade reading level per our Flesch-Kincaid formula. And we use the SMS platform Easy Texting to send and receive messages. So this was a very handy way to send and receive messages. We were able to set up the messages to be able to be automatically delivered. So we specified the time and day of delivery of the message, and the website conveniently sent those at the appropriate time. And these were two-way messages. So as part of the intervention, we did encourage people to respond to us with comments or questions. And we could see these on the website, and we had everything conveniently stored there to refer to. And we were able to correspond with participants in that way. So we were able to set up our messages both for the intervention and control group to be automatically sent using our website. And of course, we also gathered information about acceptability. So I mentioned that we had a qualitative interview at the end of the intervention. So this related to the acceptability of the intervention. So we wanted to know what were people's experiences receiving the message like? Did they enjoy that? Was it irritating? What about the time that the messages were sent, etc.? And in terms of outcomes, we had our baseline characteristics of race, age, number of children, weight, and height. And our main outcome was gestational weight gain. So we calculated this by taking the difference between the last weight taken before delivery and the weight before pregnancy, both of which were self-reported. We also looked at excessive gestational weight gain based on the guidelines that I previously showed you. And then we also looked at the acceptability of the intervention. And we calculated summary statistics to describe our sample characteristics. We used a t-test to examine differences between groups, a chi-squared test to determine if the Institute of Medicine guidelines for gestational weight gain were met. And we had linear regression models to determine if gestational weight gain was associated with the study group, whether they were in intervention or control, and with the demographics. And those variables that were significant at the 10% level in the bivariate models were examined in the multivariate model, which included age, weight before pregnancy, height, and number of children. And in terms of acceptability, of course, we had open-ended questions to evaluate that. And so we transcribed those interviews and we performed content analysis with in vivo to identify themes with regards to acceptability. We had a mean age of about 28 years old, and the mean weight at baseline was higher in the intervention than the control, but that was not a significant difference. We had 65.5% Native Hawaiian or Pacific Islander. So should mention that we allowed people to check multiple boxes with regards to race and ethnicity. And so we have included those in the count here. So we did not further classify them as being multiracial. We have included everything they checked in the counts of our race and ethnicity here in the table. And you can see their level of education here in the table as well. And in terms of attrition, 13.3% of participants did not complete the study, but this wasn't significantly different between the intervention and the control group. And so we did find that the mean gestational weight gain was similar in the intervention and control groups. So unfortunately, we did not find any effect of our intervention in creating a difference in terms of gestational weight gain. We did find that older women gained more weight than younger women, that a greater weight at baseline was associated with less weight gain. So that's to be expected and is in line with the guidelines. If a person is heavier prior to pregnancy, then the recommendation is that they gain less weight during pregnancy. And we also found that women with more children gained less weight. And we did find that at least half of the participants in both groups exceeded the guidelines. So we can see how important it is to conduct studies in this area, as we do have many women who are not meeting those recommendations for weight gain in pregnancy. And we had the overweight groups with the lowest percentage of participants exceeding the guidelines, but that was not significantly different from the other groups. With regards to acceptability, we had people respond to questions in 4 content areas: the most useful messages for staying healthy, the least useful, the messages that affected their eating and exercise habits. So here I should mention that, of course, as part of this study, we did not have any other way of measuring their habits. So we didn't assess diet or physical activity using any questionnaire or other tools, but we did ask in this interview which messages, were there any messages that led them to change their behavior? So they reported that here. And their experience of receiving the messages. So we did include an open-ended question to ask them to comment on their experience receiving the messages. And I should also mention that in addition to this qualitative interview, we did also send questions via text message during the intervention to ask them questions related to acceptability with regards to the same sorts of topics that I mentioned, and whether they liked receiving the messages, whether they were a nuisance, or etc. But for now, for this presentation, I'm just reporting the results from this qualitative interview. And the results with regards to acceptability were that the most useful messages related to healthy food substitutions. So I showed you one example of that before with regards to choosing water rather than soda. And the least helpful messages were those that people didn't perceive themselves to be able to perform. So one example of that was eating sardines for omega-3 fatty acids. I think we had comments that, perhaps that was not a food that people typically consumed, or they didn't like that particular food, so they didn't think that to be something that they would actually do. And they also stated that messages on healthy food substitutions had the most impact on their eating behavior. And most felt that increasing the number of messages would have been helpful. So of course, in our study, we only sent 1 message per week. And of course, we saw that in other studies, in some cases, there have been additional messages sent. And so that's something that we're keeping in mind for future studies as a topic of interest. So we didn't find any significant differences between the treatment groups, unfortunately. But we did find that older women had more gestational weight gain. Women with more children and those who weighed more at baseline had less gestational weight gain. So in terms of the strengths of this study, it had a randomized controlled trial design. We used a novel method in an underserved population. So as I mentioned, this was the first study in Hawaii WIC using text message to promote healthy gestational weight gain. So it was a novel study. And our intervention messages were based on recognized guidelines and cultural considerations. And so we designed our messages in line with the WIC recommendations. And we also worked with our local OBGYN to make sure that we were using the appropriate terms and that our messages were culturally appropriate for our population here. In terms of the limitations, we had self-reported pre-pregnancy weight and also had a self-reported weight prior to delivery. So of course we know that people tend to underestimate their weight and overestimate their height. So this might have affected our results in some fashion. We also had a lack of statistical power due to a small sample size. And we cannot generalize beyond our sample because of the nature of our sampling. We did not measure behaviors or dietary intake. So it would be very interesting to do so, to be able to see whether we did in fact impact behavior. Perhaps we didn't impact weight, but maybe there was some impact on behavior, because of course our goal was to prevent weight gain by changing behavior. So this would be something interesting to do for a future study. And for future research, we would like to see larger studies to increase statistical power. We can also consider tailoring to individuals. So one limitation of this study was that we sent the same messages to everyone. So we didn't, for example, assess people's stage of change. So we may have had people who were in the pre-contemplation phase, who perhaps would have benefited from knowing more about why it's important to choose particular foods in pregnancy, or why it's important to do physical activity in pregnancy. And we might have had other people who had already progressed and already knew about these benefits and perhaps needed more information about how best to implement the recommendations and gain more confidence in performing the behaviors in question. So it may be useful to personalize the messages to be able to have a greater impact on each individual given their own particular situation. In addition, we can consider varying the intensity of the messages. So of course, we only sent one per week, and we may see a greater effect if we send additional messages, especially given the fact that many women reported that they would like to receive additional messages. And it would also be useful to further encourage responses and measure engagement. So I should mention, as I did previously, that we did encourage people to respond with questions or comments. However, there were very few of these. So people didn't engage too much with us online. And so we also don't know whether or not people actually read the message. So on our end, on the website, we were able to see that we delivered the message, that it was sent, but beyond that, we didn't know if people read the message. We couldn't see if they opened it. So that would be helpful to know in terms of measuring engagement with the intervention. And we might also target additional time periods around pregnancy, so for preconception or postpartum weight loss. And we might also incorporate additional components, so a social media peer group, for example. So we could see that previous studies using technology have used various means of reaching participants, and this might help to increase their engagement. And one other thing that we have been planning is to also see if we can incorporate a friend or family member into a future intervention. So rather than just sending the messages to the pregnant women, the participants in the study, we would also send to a friend or family member to then encourage them to discuss the concepts with the participant in the study. So we're anticipating that this might increase engagement with the material, and we're currently seeking funding to do a study of that nature, incorporating the friend or family member. So in terms of our conclusions, of course, excess gestational weight gain has health implications for the mother and the baby. And we can see that even in our study, we had many people who were exceeding the guidelines. So this is a very important topic. And mobile technology is useful for nutrition interventions and removing barriers for disadvantaged populations. So we hope to be able to move beyond just face-to-face interventions to really help low-income populations to meet the guidelines. So after our intervention, we did not find significant differences in gestational weight gain between the intervention and control group. So we can focus in the future on modifying the intensity of messages and including other intervention modalities and measures, so perhaps measuring behavior, engaging with people in other ways using technology, And this research is so exciting because if we can show that this is an effective way of delivering education, then it can be adopted as a best practice by WIC to prevent excessive gestational weight gain. So we have some publications on this work. We have one publication in press that you can check out, and we have another under review. So one thing that we did as part of this study was to follow up to gather information on birth weight, and we looked at whether our intervention had any effect on that. So that manuscript is currently under review. I would like to acknowledge all of the wonderful individuals at WIC who assisted with the study. WIC has been so amazing in terms of assisting us and being a real ally in our research, and all of the wonderful students who participated in this research and helped to collect the data. So thankful to have such wonderful students. And we would also like to acknowledge our funding source, so the Mountain West Clinical Translational Research Infrastructure Network. So thank you very much for the funding. And I'm very happy to take any questions.
Thank you very much, Dr. Jinan Banna. We do have one question from Dr. Murat Traber. It asks, since you didn't measure baseline weight and the subjects were recruited somewhat after pregnancy began, do you think if you had subjects report weight more frequently, that you could compare the rate of weight gain according to your intervention?
Yeah, I think that's a very interesting suggestion and would add to our intervention. So it would be useful to come up with better ways of assessing weight in our intervention. So of course, it wasn't ideal. This was a big topic of discussion actually in terms of how to obtain the weight, because we have women coming into WIC at different time periods. So it made it difficult for us to obtain objective information on weight at a particular standard time period for everyone. So this is something we've been trying to address in planning future studies in terms of whether we may be able to gain information from the medical record. So if WIC has a case file, if we would be able to gather any information on weight that way for the women to give us some more objective measures of weight, and perhaps also look at weight at different time periods. So I think that's really an excellent thought and really gets at some of the challenges that we've had with regards to assessing weight, because of course it's not an ideal measure of weight to have that self-reported data. So yeah, thank you for bringing up that topic, and I think that's really an important point.
Yeah. Well, I invite the audience to post more questions in the Q&A box. And Jinan, I have a question for you.
Sure.
Yeah, anytime when we do mobile technology, cost, right, can be a challenge. I am curious to know in this specific intervention, what was most costly? Is it before, during, or after the intervention? And why so?
In terms of the cost incurred?
Cost incurred to, especially for software development and also implementing the intervention.
Yeah, the wonderful thing is that it was relatively low cost. We had to purchase the plan with easy texting, and in purchasing that plan, we purchased a plan that gave us a particular number, a maximum number of messages that we could send and receive. So that was quite low cost for us. And of course, there was no cost incurred on the end of the participants because we only enrolled those who were able to send and receive messages at no cost. They had a phone plan that allowed them to do that. So it was relatively low cost. And so with easy texting, we simply purchased that plan. We then set up in easy texting our messages to be automatically sent. And easy texting helped us to do that. We were easily able to go in and look at when we were receiving and sending messages. So it was pretty straightforward and low cost.
Thank you. Let's see. Yes, we have another question from Dr. Roberta Reportella. It asks, some app weight control programs are claiming large success. Noom uses multiple touch points. Have you considered expanding the type of content you could use to give pregnant women encouragement, know their triggers, and etc.?
Yes, definitely. So I mentioned that it's also important in thinking about achieving healthy weight to take into account motivation, concerns about body image. So I think we need to think, much beyond just giving education, giving information about what to do and why it's important to do it, but thinking beyond this and about some of the psychological factors that might be impacting the weight of some of these women. And so some previous studies also pointed to this, the importance of this. So yes, definitely. I think that's a very excellent point.
Wonderful. Well, right now we don't have additional question. Let's see. Maybe one more question for you, Jinan. I'd like to ask a little bit more about the personalized messaging, right? What would you do differently, other than what you mentioned, based on, so let's say, what would you start launching in fall this year, given the change in technology and also COVID-19, in terms of doing an intervention like this in times of crisis to help the pregnant mother, right, not gain excessive weight?
Mm-hmm. Yeah, so I think it would be, first of all, very interesting to better understand our participants and their particular needs prior to determining what messages we're going to be sending them. So I mentioned the stages of change. I think, along those lines would be very helpful to understand, what they already know about the topic, where they are in terms of the stages of change. I think that would be quite interesting. And then I think it would be quite interesting to have more interaction. So people posing very particular questions about their own situation, maybe gathering information on barriers that they face in terms of trying to implement the strategies that we're suggesting, and just making it much more personal. So having more interaction and better understanding the situation of the women in question.
Absolutely. Thank you. Well, seeing no other, oh, wait, there's one more question. Let's see. This is a comment. No, this is a question. Let's see. From Michelle Katina. Thanks for a great talk. My population of interest in caregivers of children with disabilities. I plan to use technology, likely test messaging, to deliver an education intervention. Do you have anything you learned during your study that would be helpful?
I guess I would think it very important to, as you mentioned, engage caregivers. Of course, engaging caregivers is such an important part of interventions with children, even without disabilities. In any case, to engage caregivers. So I think, it would be helpful perhaps to better understand, that population of caregivers, thinking about what are the characteristics of that population and devising the messages, with the appropriate cultural considerations in mind and with the appropriate reading level, and perhaps conducting some formative research prior to engaging in the intervention to better understand your population of caregivers. So I think those are just general, very important uh, things to consider before conducting any intervention. And then I guess, I would review the literature on this particular topic with children with disabilities and see what interventions have been previously conducted in caregivers for this population. So I think I would be very interested to know more about what you decide to do in terms of if you decide to personalize messages, I think that's something that definitely we learned in this study, that perhaps some of the messages were irrelevant for some of our participants. So I think that is a very interesting point. And perhaps considering engaging caregivers using other modalities. So thinking about something beyond text message, and considering the types of technology they're using, and whether or not text is the most appropriate way, or whether there's some other way that might engage them even further, such as using a website or an app. So I think that's really exciting, and I would love to hear more about what your plans are for the intervention.
Thank you. Let's see. Jinan, what about chatbot? Have you considered that?
What about, say again?
Chatbot, C-A-C-H-A-T, chatting, like robot in text message. So something with the artificial intelligence built in, but then, we would chat with this little chat box. Sorry, not chat box, chatbot, right? And that it will still answer some of the questions and staying in touch with us from time to time.
No, I haven't considered that, but I would love to learn more about it.
Well, I started trying something called the Woebot, W-O-E-B-O-T. So check it out. It's more for mental health.
Awesome. I will do. Thank you.
Well, thank you everyone for joining this excellent talk. This is a wonderful seminar, and thank you, our speaker, Dr. Jinan Banna, for sharing your talent, your experience with us. And so, well, I wish all of you a wonderful weekend. And if you would like to stay for a few minutes to ask additional questions, you're welcome to. Goodbye, everyone.
Thank you.